Hello and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. In this episode, we ask, what's stopping people from taking HIV PrEP, and how can we address these barriers in practice? To answer these questions, we're joined by Dr. Bedimo from the University of Texas, UT Southwestern. For more information about Dr. Bedimo, including downloadable slides you can use to follow along, please visit the links in the show notes. And to get access to all of our new podcasts, you can subscribe to the CCO Infectious Disease podcast. Do it on Apple Podcasts, on Google Podcasts, or on Spotify. Now let's get started and join Dr. Bedimo as he discusses PrEP barriers.
So let's look at breaking down key barriers. Overview of PrEP barriers at the individual and community perspective. So there is low awareness, there's low perceived risk. A lot of people who acquire HIV did not consider themselves at risk. That is a big issue. And then stigma, sometimes healthcare related, people have negative experiences in healthcare settings at the community level, at the individual level, racism, homophobia, mistrust of the healthcare system, competing priorities. When somebody's trying to put food in the table and they have challenges with housing instability, they're really not ready to address this type of issues. So we need to be aware of all that, and the limited options for those having receptive vaginal sex are to visit letters. So unfortunately, many options have not been adequately tested for people having receptive vaginal sex in terms of preventing them from acquiring HIV. And we'll discuss a little bit. So we have here key barriers and how we can address them. So from adolescent, we need to understand that the dissatisfaction with medical team and lack of support issues, race and ethnic minorities, mistrust, cisgender women, competing priorities, poor awareness and low perceived risk, and transgender individuals. People are worried about drug-drug interactions between gender-affirming hormone therapy with HIV medications. You need to reassure them that there's no significant interactions so that they should not worry about that. So people who inject drugs, costs, and other social barriers. So interventions to support PrEP adherence in 3 different groups: delivery, support, and regimen. So provision of PrEP in settings that are not the traditional one, people already frequently using those settings, like the primary care people, pharmacists prescribing PrEP, integration and co-location of PrEP and other services like OBGYN and treatment for opioid use disorder. And then there are support systems, computer, phone-based counseling, peer-based support, navigators. In the poll earlier, few people had these wraparound services and support systems like navigators, text messages and training, as well as regimen. So offering PrEP modalities and dosing options that may appeal to people. Some people who do not want to take daily oral PrEP might be more willing to take every other month injectable PrEP. So offer that to them. We have the on-demand PrEP because it's off-label. It's recommended by IAS USA, WHO, but off-label in the United States. So then we have daily FTC TDF and then daily FTC TAF, as well as injectable cabotegravir. These options, daily oral FTC TDF, daily oral FTC TAF, injectable cabotegravir, all FDA approved for all these groups: men who have sex with men, transgender women, and cisgender men. Much fewer options available for cisgender women because daily oral FTC TAF was not adequately tested in that population, so it's not recommended. Again, only daily FTC TDF and injectable cabotegravir are recommended for cisgender women and transgender men and transgender men. So there are only 2 options for cisgender women: daily FTC TDF and injectable cabotegravir. So now what's the data on efficacy based on adherence? This data comes from the IPREC study, which compared daily FTC-TDF to placebo in men who have sex with men and transgender women. The good news in that study, which is not something to recommend non-adherence, but the good news was that the sweet spot was actually 4 weekly doses. So if you took all 7 doses in the week, your efficacy was 99%. But you're paid down close to that if you took only 4 of the 7, 96%. Things fell off when you took fewer than 4 doses per week. So that's important to note. So efficacy in initial studies was deemed to be lower for women. So that sweet spot of 4 tablets a week for men, it was assessed by 2016 that it would take more for women to ensure effective drug concentration in vaginal cervical tissue. There is one reassuring data that came out of a pooled analysis of cisgender women receiving FTC-TDF for PrEP. And that showed that they also, in that analysis, had a high level of efficacy with more than 4 weekly doses. So that is a study that was presented at CROI last year and published by Jean Marazzo. And I think it's important to give more confidence in the efficacy of that modality in cisgender women. So, and then the long-acting cabotegravir dose also showed to be rather forgiving, because if you delayed the injections by 8 to 12 week delay in dosing, you still had significant cabotegravir concentrations that would offer you protection. So there's some forgiveness to that. Again, good news. Again, that's not to say recommend people to skip doses. So that's or delay doses. So in comparison to FTC-TDF, FTC-TAF for PrEP, the efficacy in cisgender women is not clear. Neither is for injection drug users. Things that some people worry about, which the safety of these respective drugs. The bottom line is that FTC-TDF is more likely to lower bone mineral density than FTC-TAF, while FTC-TAF is more likely to increase lipids than FTC-TDF. So FTC-TDF is generic and has on-demand options. So safety and efficacy of FTC-TDF in a pooled analysis. In these 72 studies of individuals receiving FTC-TDF for PrEP across 28 countries from June 2011 to September 2019, you can see that HIV incidence was dropped significantly when the number of pills prescribed were 4 or more. So that's very reassuring. And then few participants with detected resistance associated with FTC-TDF in that study, and low incidence of bone or kidney adverse events. So that is also comforting, because some people are reluctant to take FTC-TDF because they're worried about kidney and bone side effects. So there were fewer in this pooled analysis. So comparison of FTC-TDF versus cabotegravir for PrEP. 2 big studies were published in the past couple of years, HPTN 083 in men who have sex with men and transgender women, and HPTN 084 in cisgender women. Both studies showed superiority in efficacy of cabotegravir injectable to FTC-TDF. And again, you just have to compare the relative tolerability. There were similar rates of renal adverse events between the group. Cabotegravir were unlikely to cause renal toxicity, the mechanism. And in HPTN 083, there was some weight increase in cabotegravir versus TDF in the first 40 weeks. The weight change similar later. And then you can see the result for HPTN 084. Again, there is some concern in the community that integrase inhibitors use is associated with a significant weight gain that limits the acceptance of some people of them, but this data is reassuring that wasn't significantly a problem. Now comes pregnancy, PrEP in pregnancy and breastfeeding or chest feeding. So pregnancy associated with increased risk of HIV acquisition, that's important. So it's important, therefore, to make sure that prevention doesn't cease during that time. And FTC-TDF daily is recommended for PrEP. widely used, no link to teratogenicity or in pregnancy registries. Data from lactation studies in women with HIV suggest limited drug exposure and no differences in pregnancy or prenatal outcomes. So safety concerns of pregnancy and effects on fertility are barriers to PrEP uptake. So if a person becomes pregnant while receiving long-acting cabotegravir, discuss limited safety data and given the long half-life. However, it's also important to note that dolutegravir is now a preferred agent in pregnancy, having superior outcomes for pregnancy outcomes. And so it's important to know that that class of drugs may just be proven later to be good in pregnancy. So drug-drug interactions with gender-affirming hormone therapy in general, and this is bold and italicized, most gender-affirming hormone therapy do not interact with HIV medication, especially now that most regimens include integrase inhibitors. So new reassuring data on PrEP, FTC-TDF does not alter estrogen or testosterone levels. No interactions observed between long-acting cabotegravir and gender-affirming hormone therapy, but on-demand PrEP should be used with caution in transgender women receiving gender-affirming hormone therapy because estrogen may lower level of tenofovir.
Thank you very much to Dr. Bedimo, and thank you to our listeners for joining in. As a reminder, to view the full program on contemporary HIV treatment and prevention 2024, click on the links in the show notes for this episode. And please be sure to check back for more episodes on important infectious disease topics. Thank you, and we'll see you on the next podcast soon.